So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening. Hi, everyone. Welcome back. It's so good to see some familiar faces and some new ones. Thank you all for joining us. I know it's been a minute since we've been back in South Florida with this amazing team from Memorial, and we could not be happier to be here. Thank you to all of you also watching live. For those of you who may not know me, I'm Danielle Hicks, and I am Chief Patient Officer at GoTo Foundation for Lung Cancer. My role is to really oversee all of the work that we do with the patient and caregiver population around support and education services. So a little bit about myself before we start. So my journey within this lung cancer space began in 2003, and some of you already know this. My mom, Bonnie Adario, was diagnosed with stage 3B non-small cell adenocarcinoma. At that time in 2003, she was told that there was really nothing that anybody could do for her. They said maybe they could try some chemo, but because of the location and the fact that it had impacted her aorta, they really didn't think that chemo was going to help much. So that not being a really good answer for her or my family, we kind of put together a multidisciplinary team of our own. Doctors from several different hospitals. We just put the feelers out, and I think it's an important kind of segue into what we're talking about tonight in this multidisciplinary space and why it's so important. I'm happy to say that outreach did wonders, and on March 17th, St. Patrick's Day, we celebrated her 19th year of being cancer-free. So, yeah, thank you. I'm gonna turn things over to Dr. Raez to introduce this amazing team.
Okay, my name is Mihaela. I have been a nurse navigator since 2017. My background is obviously a nurse. I started in oncology as a research nurse, and I continued as a navigator. I feel truly privileged to work as a facilitator, to help patients to navigate through their process of cancer care. My goal is to make sure you have facilitated access to care, that you have all the information that you need to make your own decisions about your care. The most important part of the day is to make sure you get the best experience with Memorial, the best service that we can possibly offer you.
My name is Mark Block, and I am a thoracic surgeon, which means I do surgery in the chest and with a specific focus on the lungs and therefore lung cancer. I finished my training in 1997, and that included a 3-year stint at the National Cancer Institute, where we were actually doing some of the very early work on immunotherapy, so it's really exciting to see that finally come to fruition. I think over those 20 years, what we've seen is the role of surgery, rather than shrinking, it's actually growing. And I think that's the whole concept of the multidisciplinary team is becoming much more integrated. And I think that's a testament to the developments in all of our individual fields, and we can address those later. But there have been advances in surgery, in oncology, in radiation therapy, immunotherapy. And rather than separate our specialties, it's actually, I think, brought us more together and helped us function more as a team, as an integrated team, bringing everyone together for the patient.
My name is Raez. I was born in Peru, and I came in 1993 to the United States. I graduated in 1999. For the next 20 years at the University of Miami, and now 10 years at Memorial. We are very passionate to fight for our patients, to look for always the options to cure them or to prolong their life. And I think, with the help of a multidisciplinary team, this has been successful, Sometimes it's the surgery, sometimes it's the biopsy, the radiation, the protocol, the new drug, but there is always hope because we are trying to fight. And that's why this is a very important cause to me, and I decided to dedicate my life to fight lung cancer, and it has been the first 10 years were very difficult because I thought maybe I make a mistake, because we didn't have too many developments, and now we are so excited about molecular therapy and things like that, and we are going to fight for you always, and we'll never give up.
is Ana Botero, and I am also a foreign physician. I'm from Colombia. As I said, joking, in my other life, I was a surgeon, and I retrained in St. Louis, Missouri, in Washington University as a radiation oncologist. But as a radiation oncology, technology makes a huge difference, and we have different technology for different staging of the cancer. So if it's an early stage and the patient is not candidate for surgery, the good thing is just discussion. What is the best for the patient? So early stage, we have now radiation with very good results also for those patients that are not candidate for surgery. Locally advanced, thanks to the chemo, thanks to the target therapy, immunotherapy. Now we see patients surviving longer, surgeons being a little more aggressive because of the benefit of even doing surgery for those that for many, many years we used to say they are not candidate for surgery. And I think that one of the major achievements is for those stage 4 that sadly still we see probably maybe a third of the patients or maybe more. Eventually they develop more, not necessarily at the time of the diagnosis, but during the years pass by, they develop metastases. But for those patients that we know that they have a little bit more some special individualized targeting, that they can do with target medicine or with the immunotherapy, radiation also help tremendously, because we know that given doses that we never thought that we were going to be able to do it with the technology available, we escalate the dose, we target those lesions, we eradicate. We're not talking about just palliate the pain or the obstruction, we eradicate the disease. And we know that by doing that, your own immune defenses and everything, plus the immunotherapy and the systemic therapy, the patients do much better. And we have the, prove among here many patients that basically they kind of go from one treatment to the other. They go for a period of time without no treatment, but certainly for those patients, radiation helps a lot. But I think that the future is just having a lot of hope for cure the cancer.
My name is Gelenis Domingo. I'm one of the medical oncologists, a thoracic oncologist at Memorial. I trained under the supervision of Dr. Raez, who's my mentor, and he was one of the big reasons why I decided to do lung cancer oncology, in addition of disease that's still being the #1 cause of cancer death, and having so many new discoveries that make it very exciting and gives us a lot of hope that we can now cure so many more patients. I remember when I was a fellow and you had a diagnosis of stage 4 lung cancer, it was pretty much a death sentence. And now we're seeing so many patients that are in remission for so many years that I think, it gives me a lot of hope. And I can also see that in Dr. Raez, who's a leader in our department, also spearheading a lot of the research that we're doing at Memorial. And that's one of the main reasons I went into lung cancer.
Okay, so this is supposed to be interactive, so we really want to hear some comments and opinions. And first of all, I want to acknowledge the caregivers, the friends, the spouses, because we have learned in this journey that the patients are the ones that are suffering, but the caregiver is not allowed to say that he's suffering or she's suffering, He only is silent, always next to the patient, and I have learned that a lot of them carry a tremendous burden, and I have family members also that have had cancer, and so I realized that this is very important, that also as cancer programs, we are with you. We really care about the caregivers, and we can provide some sort of support to you too. And that's important, because we're talking tonight about multidisciplinary care. And we don't have time to present everything because, we have here navigator, surgery, medical oncology, radiation, but we also have pathology, we have nutritionists, we have integrative medicine, we have palliative care, we have pain management. That's why I think the management of lung cancer has been improving tremendously, because now we acknowledge that we have to fight every corner of the disease. We cannot do anything left behind. If a patient is depressed and doesn't come to the treatment, doesn't matter if you give him the best treatment of the world, he will not come, Maybe I want to ask, now we'll start this way, Dr. Domingo, maybe you can mention briefly, what are the the developments, because the patients ask a lot about target therapy, precision medicine, molecular testing. Maybe you can do a 5-minute glimpse about what we're doing for that.
So there's a lot of new discoveries. It's a very exciting field. There's now personalized medicine in terms of systemic therapy for cancer care. And it includes targeted therapy, immunotherapy, especially for late-stage patients. We always send molecular testing so we can determine the biology of the tumors, so we can better decide what treatment would work best for every specific patient. And every day we're finding more and more different targets that we can treat patients with. And those are, very, very good because they're oral therapies. Patients avoid all the side effects that we typically see with chemotherapy. And usually the survival and the prognosis of a patient that's found to have a target is much better than someone that doesn't. In addition to that, we also treat patients with immunotherapy. And we're seeing many patients that are very good responders to immunotherapy, and also their prognosis has improved significantly. We're also moving that treatment now in the earlier stages of lung cancer. So now molecular testing is not only recommended for later stages of lung cancer, but also we do it pretty much for all stages. And now we have some recommendations to treat patients even before surgery, to shrink their tumors before they undergo a surgical procedure, which sometimes can also prolong survival or make their surgical outcomes better. And so a lot of new things that are coming in lung cancer. These are very exciting times.
Great. And also, maybe you can emphasize about that what we want is to empower you, the patients, about this. You have to request your doctor to do molecular testing, because sometimes molecular testing is not perfect. Sometimes there is not enough tissue. Like 20% of the time, there is not enough tissue. So for the doctor nowadays, if you have a lung cancer, say, I'm sorry, there's no molecular tissue, you get chemo. That's not good. You have to tell the doctor, why you don't do a liquid biopsy? Send my blood, give me a second chance, maybe we can find a molecular target, so instead to have chemo, I can have a pill. Yeah, but I think we need to empower the patients and the advocates, because if you guys request that, there is no way that we don't do that. But nationwide, only half of the patients with lung cancer are having molecular testing. Only half. Yeah, that's why it's either the insurance or the doctor or the pathologist that said there is not enough tissue. So there is a lot of problems. But if we empower you, this is your right. My dream is to have one of these presidents of Congress to say, okay, the molecular testing is a right. So everybody has to have molecular testing paid, because otherwise you don't practice modern cancer care, Giving the same chemo to everybody doesn't cure people. So that's why this is very important. Yeah, that part of this message is molecular testing is important. Each of you have to have the molecular testing.
Dr. Raez, and if I may add, usually for these companies that run the test, they'll try to bill the insurance, but if the insurance doesn't cover the test, they typically do not bill the patients, they'll cover the cost. So the patients don't end up getting billed for the test anyway. So really, everyone should be getting tested.
No, and this is important because sometimes the doctor said, maybe if I already ordered the tissue, molecular testing, the liquid is not indicated, why am I going to order? No. Most of these companies, they are in the side of the patient, they will write off. So that's why we don't have issues in our patients ordering liquid tissue, all the molecular testing. But every patient has to have the molecular testing. That's the most important thing. Otherwise, there is no precision medicine here.
And if you agree with me, the tests are complementary, so really everyone should be getting both, because sometimes you have a result in one, but it's not seen in the other. But as long as you have it in one of the two tests, that's already good enough to get the therapy that the patient would benefit from.
Yeah, that's very important, because, for example, today we do the molecular testing in the tissue and do molecular testing in the blood. And sometimes the guidelines say, only do the tissue and you don't find anything doing the blood. But you guys, as a patient, you already are waiting as an average 90 days before to get a medical oncologist, and now it's not acceptable. I tell you, now you have to wait 4 weeks to tell you what is the treatment, because that's what the tissue time takes to do the molecular testing. So that's why we do, for example, at Memorial and many academic institutions, we do the tissue and blood at the same time for the molecular testing. And in 7 days or 9 days, we get the liquid, the blood, and we can tell you what is your treatment in 9 days, most of the time. So that is why you don't have to wait. But as Dr. Domingo said, we need to order both. And this is something that we are pushing nationwide, to order both, and don't wait for the tissue to come back 3 weeks later to say, oh, there was not enough tissue, so now we order the blood and the patient keeps waiting for treatment. Yeah, so that's very important. This is something that we have to push and change with the help of the advocates and patients, because that's going to something that benefit the patients, you know.
Dr. Raez, can I ask a question? Is it reflex testing? Is that what's happening at Memorial and or Baptist, or does it have to be ordered? And if you could explain what reflex means. And then what are you ordering? Is it a comprehensive profile? Are we just looking for the 10 or 11 different mutations?
So the reflex testing is what happens in breast cancer. You know, if you have a biopsy of the breast, not only they tell you it's an adenocarcinoma of the breast, they also tell you the markers. They tell you the ER, PR, HER2. So the pathologist sends you a report 2 or 3 days later, complete. There is nothing else to say. In our case, the pathologist said it's a lung cancer, adenocarcinoma, and then he waits for me, or Dr. Domingo, to order the test and wait the 4 weeks. So that's why we keep also pushing the pathology organizations that they have to own and embrace the reflex testing. The same as they do for breast cancer, they should do for us. You know, they say, oh, this is a lung cancer. Before the sample leaves my desk, I went to all the genetic testing. So when the patient goes 2 weeks later to see the oncologist, the genetic testing is there. So we don't have to waste 2 or 3 weeks. That's called reflex testing. That is not standard of care for lung cancer. It's standard of care for breast, but not for lung. And the testing has to be next generation sequencing, NGS, because we have in lung cancer 10 genes that are targetable. We have pills for 10 genes. So to do one test, to do 1 gene, 2 genes, 3 genes is not worth it. It's actually more expensive. And also, we know that there are another 100 or 200 genes that are important. Of course, there is no treatment. Somebody say, why you want to test 200 genes if you only have treatment for 10? Because for the patients that don't have the 10, they have to have hope. Because if we have research drugs for gene 11, 12, 13, and 14, the only way I can treat these patients with the research drugs is if I know which are the extra genes. If I do the minimum, I will tell the patient, oh, you don't have any of the 10, bad luck. No, you know, we have a lot of new drugs for the genes that are not FDA-approved drugs, so that's why we have to do genetic testing, very comprehensive, and our technology allows today to check 200 genes, 300 genes. Actually, the cost is more or less the same. You know, to do 30 genes or 300 genes is the same platform, so it's not much more costly.
So we're talking about it in this instance, I guess, at diagnosis, but can we talk about progression? When somebody truly progresses, what does that look like, and why should we be rebiopsying and relooking at what's going on with their cancer?
Dr. Domingo?
Yeah, so a lot of times, especially for patients that we're treating with targeted therapy, let's say a patient that has advanced stage lung cancer and is on an oral therapy for a specific target, and they start to have some type of tumor progression. Well, at this time, we can always also consider, depending on how many sites of metastases the patient has, sometimes we consider radiation therapy, but typically it is indicated for that patient to get retested, because sometimes the way that the tumor is growing is it develops a mechanism of resistance to that drug, and sometimes the way that is resisting the drug sometimes is another path that we can target with another targeted agent. So it's very important to retest all patients to see if there's an option to change therapy to another targeted therapy, and the patient, you know, can respond and do well, and we can prolong their survival that way.
And I think, sort of to tag on to that, because you did bring up radiation, Dr. Botero, so the big fancy word is called oligometastatic or oligoprogression, right? So in that instance where maybe the cancer hasn't progressed far and wide, but is in 1 or 2, or I'm going to let you answer this question, what role does radiation play, Dr. Botero?
You know, not all the stage 4 patients are the same. And, you know, for many years now, we know that patients that present with a relatively small number of metastases, we have the opportunity to treat them more aggressively. In terms of radiation, eradicate, basically we have the technology now to target those lesions with a lot of accuracy. So escalate the dose and not necessarily giving more side effects, actually less side effects. Even as you mentioned in your personal experience, now we treat you know, tumors that are by the heart or by the aorta or by very, very critical structures without no damaging. So for those patients, definitely when we call oligometastasis, there are few. We have multiple terms. Synchronous when they present with the primary tumor at the time of the diagnosis or during those 3 months. We have metachronous. But eventually, we have this term that after they respond to the therapy are oligopersistent or oligoprogressive. And also the insurance company have become really savvy on that, and they deny treatment with high radiation technology for those patients, which is really sad, because all of them, all the gamma, you call it, if you divide it in 4 groups or 9 groups, because now we have to use the right term, they have benefit. And they say, well, doesn't really make a difference because that patient, you're not changing, you're maybe increasing the local control of the disease in that spot, or maybe you are decreasing the symptoms, but in the reality, the data show that translating survival, overall survival, disease-free survival, and even longer interval of time without need to change the immunotherapy or the target therapy, which is amazing, because even from the point of view of the system, also they are not only the patients benefit, but they also benefit of that. So even those that are, we call them polymetastatic, that at the beginning, they present like a Christmas tree when they use the immunotherapy or the target therapy, and they present now with an oligopersistent disease, they have the benefit. So I think that all the science, everything is changing for good for the patients. We have to individualize the case. We have to look at the patient. I make emphasis, we do not treat reports. We don't read the report and say, oh, this patient has 4 or 5. Many times happened to me that the report said 4, 5, 7 new brain metastases, and I go back and see which one we have treated before, and indeed they are the same lesions. So you get an enthusiastic radiation oncology with a new machine, and you get retreated. And the thing is that we nowadays, because we see patients that are survivors for so many years, we now have to be more careful with the technology that we use, because we really certainly want to do good to the patient, but not to make it worse. We have to individualize. We have to individualize in the way not only the therapy, but also the patient, and take in consideration what he wants and what is the risk. But we are walking with the physicians. We have to be very careful because we are walking to eventually see side effects of the treatment that we gave. So the higher technology in radiation that we use, I guess for Dr. Block is the same thing, and for the medical oncologists, we have to be careful. And now we're synergistic. We are using, both therapies that are very potent. So we see the good results, but the potentiation for the side effects. So we are now walking on those days that we have to figure out how is going to be the timing for those therapies, how to obtain the good result, but minimize the potential for side effects. So all these things has to be discussed with good communication among us, the physicians, and communicate with the patient and try to explain it in more kind of a simple way, because they have to be aware that, science is science, we're human beings, we wish to do the best, like I have the power of some God, but we're not, and we have to really make them aware of the potential risk, the potential benefit, and let them also participate obviously from that decision. But communication is clue, and being aware that these patients nowadays, even if they present with a polymetastatic disease, you can see them walking with a no disease 5, 6 years later or even longer.
Yeah, I love the way you talk about risk too, because I think it helps to sort of demystify radiation therapy, because I think a lot of people are afraid of it, right? And to really understand, we talked about, I think Dr. Domingo or Dr. Raez, you brought it up, technology, right? And how far technology has come, whether it's chemotherapy, targeted therapies, and immunotherapies, and how we're getting access to information. And
main competition for us is Dr. Google. Patients come, and the first word, basically the nurse said, you're going to see a patient that do not want the radiation, that read that he's going to be dead in 6 months, horrible prognosis. Why do they have to go to the treatment, right? So, and it's totally wrong, because it's a curve. Now with all the things that we have, that curve embrace patients that are going to be survivors and with good quality of life, or minimal things, that they can live with. So the first thing when you see a patient is actually to do a little bit of brainwash against the Dr. Google.
It's true, because I think recognizing that the technology is always evolving and getting better, right? But now it's not your grandfather's radiation therapy. I mean, you're able to target, and the radiation field is so much smaller and so much targeted than it used to be, so you're not damaging all of that healthy tissue. So I appreciate you talking about that. And I'm not trying to hijack your conversation, Dr. Raez, I'm sorry.
No, it's perfect. So I was going to ask Dr. Block, for 20 years, we are giving chemo after surgery because the chemo before surgery that didn't work very well. Our lung cancer chemo don't shrink the tumors very well. Totally different from breast. In breast cancer, pretty much I think every lady before surgery, he has to go for chemo. But in lung cancer, no, because the chemo didn't work. So that's why in lung cancer, traditionally, the chemo is after surgery. But if you hear the news in the last 2 years, now thanks to the immunotherapy, we are starting to do more immunotherapy before surgery. So I wanted to ask his impression to Dr. Block. What is the change in this paradigm?
So the role of combining surgery with chemotherapy has been an interesting one over the last 20, 25 years. I think when I first was in training, stage 3 disease, which was a lung cancer where the lymph nodes in the central part of the chest are involved, was generally considered a non-surgical disease. And we were doing a procedure called mediastinoscopy, and if the nodes were positive, the patient was not going to have surgery, they'd go for chemotherapy. And what we've seen, I think, over the last 5 years and 10 years, really, is that as the chemotherapy, medical therapy, immunotherapy has gotten better, there is now more of a role for surgery combined with these treatments. So now, for example, stage 3 disease, I mean, you know this, we will give them preoperative treatment and do surgery, or surgery and discover it and do postoperative therapy. Immunotherapy is probably one of the most interesting things for us as surgeons, because we are seeing a kind of response that we never saw with chemotherapy. One of the advantages of being a surgeon is you actually physically get to see and touch the tissue. You see what happens. Immunotherapy harnesses the immune system, which is a multi-pronged attack on cancer cells. It's not the chemotherapy that you target the cancer cell and you make the cancer cell die. With immunotherapy, you're harnessing the immune system to attack the cancer cell. You get an inflammatory response, you get a whole host response. So the cancer cell doesn't just die, you now get scarring and inflammatory reaction across the whole field, which is creating an interesting challenge for us as surgeons, because the surgery is now getting to be more complicated. It used to be fairly straightforward, but now that we're seeing patients who have immunotherapy first, the surgery is a little bit more challenging. There's a lot more scar tissue to deal with. And centers around the country we're kind of pooling our data. I just came from a meeting with a bunch of thoracic surgeons from around the country, where there's a lot of conversation about, let's talk about our experience with these patients. Now that we're starting to see patients who've had immunotherapy, these are patients who never would have come to surgery to begin with. They would have gotten to chemotherapy, probably would have progressed, never would have had surgery. Now they're getting immunotherapy, they're having a good response, and we're approaching the surgery as potentially curative. And it's a challenge for us as surgeons. One of the things that kind of makes you want to come to work the next day is that you're learning something new, you're seeing new things and exciting new things. So it's an avenue that's opened up for us as surgeons that I think is very exciting.
Right. Yeah, I think as a medical oncologist, it's also very exciting, as I said, because we used to wait for the surgery to give chemo after that to try to decrease the chance of recurrence. But nowadays, with the immunotherapy that we give before surgery, the tumors shrink tremendously, something that we didn't see before. And hopefully, that will increase the number yet to patients that can go to surgery. That's something that we haven't proved yet. So far, we are shrinking the tumors, but what we really like to do is to have patients that didn't have a chance of surgery, and now we make it, they give a chance of surgery, so we can apply the multimodality therapy. We can do the immunotherapy, we can do the surgery, maybe the radiation, the chemo, so the patient benefits for all the interventions. Maybe we can ask Mihaela, one of the things when we want to have program. You know, I think multidisciplinary teams for any cancer are programs. And one thing, for example, for our program, as we mentioned, is different specialists. And I guess everybody agrees that if Dr. Block does lung surgery, biliary surgery, colon surgery, it's not the same. You know, it has to be dedicated. And the same with Dr. Domingo and us, we're trying to focus only on lung cancer. But the navigators are very interesting, you know. So sometimes for us as a doctors, it's a challenge to convince the administrators of the healthcare system why we had to hire navigators. You know, I remember I had to go to the president of the healthcare system to convince him to hire 5 navigators for the cancer center 10 years ago. And not because he was against, he said he didn't know why we needed to do that, so he invited me to have breakfast and convince him, and after he finished talking to him, he said, okay, we'll hire them. But why is so important the role of the navigators in cancer?
When the patient is referred to oncology, most of the time we are the first contact to the patient. So they don't know where they're going, why they're being referred. Most of the time they're scared about calling an oncologist to make an appointment. And my role, first of all, is to make sure they get an appointment within 72 hours, 48 hours if possible. And I get the records from whatever we have available. If they have a biopsy, we schedule the patient right away. If the patient, for instance, doesn't have a biopsy, and he sees or she sees an oncologist, then we are delaying the patient's care because then we refer the patient for a biopsy. So my role is to understand the patient's story, review the records, and obviously discuss with the oncologist. If the patient needs a biopsy, we refer the patient to the thoracic surgery or to pulmonology. So we speed up the process. It's very interesting that Dr. Raez has initiated a multidisciplinary clinic. Usually it's Tuesdays. On Tuesdays, so patients newly diagnosed with cancer, then they need our meeting with radiation oncologists, medical oncologists, and surgical oncologists if needed. So my role is also to help the patient to have all the appointments scheduled and also communicate with oncologists whatever issues we have related to that. So this is somehow helps patients and to get access to care, get obviously the staging completed right away as fast as we can, and also we facilitate their treatment to start right away as far as we can, and in terms of results and all this. So I feel like first of all we're saving time, we're saving lives, just making sure everything is done as fast as we can. Another thing that's very important for us besides that, a lot of patients are not able to get access to care, and they don't speak up. They see the doctor, and then after the appointment, when I follow up with them, sometimes I notice that they're so confused and so anxious about the whole new thing about what is this, what do I need to do, what's a biopsy, why do I need to see a radiation oncologist or a surgeon? I'm afraid of that. So my role is to make them understand the importance of following up and following through what they need to do. So in terms of leading them to have a successful experience with us and see them fighting this cancer, I think the role of the navigator, generally speaking, is as important as any other team member or medical team member, because sometimes patients cannot come to the appointments because they cannot eat, so we have nutritionists. So the patient may not say at the appointment, but then following up with them, we realize they cannot eat, they don't have transportation, or there are other things that we cannot really discover at one appointment. It's always a reinforcement, always an assessment. So that part is the back of the ground of this work is carried out by the navigator as well. Also very important, I feel like we have to be an advocate for the patient. Sometimes, as we all see here, it's been like a very long process. So the worn out part of the caregiver and the communication with the patient and the caregiver sometimes it helps the patient to continue and try new things and understand why we need to switch treatments. Why is this important? I don't want to give up. Some patients want to give up, but then discussing with them and see by example what are the benefits of continuing the treatment. It's very rewarding. At least for me, that's I have seen in a few years. I've been really amazed about the resilience of patients. But also I realize our role is as important as it's to really connect everything and keep it together so that the patient will have such a successful outcome. In terms of, we have something that we always try to also implement new things. Like recently we have financial navigator. We all know what does it mean to have insurance, co-payments, and sometimes it becomes a burden for patients. They don't want to come to the appointments because obviously there's overwhelming, invoicing is too high, or things like that. So we have recently implemented for lung cancer patients a tool that's called financial toxicity tool. And helps patients to help us to identify what, let's say, issues that the patients have. So we have a financial navigator reaching out to them and so forth. So our role is throughout this process of helping patients through cancer care is never ending. It's always something new. Survivorship is also important. We connect with patients on and on. We explain what is the psychologist, why is it important for the caregiver to come and be a part of the process with the psychologist and the patient. What are the benefits for you? The social workers, sometimes patients go through different other issues because life happens. So we want to make sure we stay connected with other professionals and help them out on that particular aspect. So I would say as we know, a lot of treatments are new treatments. We also connect with the research team. And if we identify a benefit besides Dr. Raez and the other oncologists, if we know that we will find something that will help the patient in terms of research, we also connect with the research department to discuss that. There are a myriad of tools that would help patients, and we all understand that everyone's story is very unique. So the navigator, my mission is to make sure we tailor everything as much as we can, our care, to help you as much as possible.
Great, thank you.
Sure.
You guys want to ask any question, any comment? Yes, please.
Thank you. First, I want to thank Dr. Block for the good surgery you did on me, and Dr. Botero for finding a blood clot that others weren't able to find. So thank you so much. My question is regarding sugar. There's been a lot of controversy about eating sugar. I'm very fond of chocolate, and I've eaten chocolate throughout the years. Chocolate's my friend, but what's your take on it? Anyone?
So, yeah, I get this a lot. You hear a lot of mythology in surgery, like, cutting on cancer makes it spread, and should I avoid sugar? I'm not sure where that came from. My take is that we use PET scans to diagnose and stage cancer. Okay. And as all of you probably know, cancer cells take up the activity on a PET scan. Well, the chemical that you're given when you get a PET scan is glucose, it's sugar. It's radiolabeled sugar. And so sugar is the fuel source for all the cells in our body, except for the brain. So the cells that take up a lot of sugar show up bright on the PET scan. So I guess somebody made the leap of, A plus B to C to D to E, is that, well, if you're given sugar to light up the cancer, then the cancers must feed on sugar, so you probably shouldn't eat sugar. That's my guess, and I'm open to alternative theories.
You can quit on the sugar. You will kill the person, the patient first. You certainly cure the disease, but really basically kill the patient. Patients lost weight, they are losing the most important thing, that is their own immune defenses. I think that balance, for me, but I don't know from where these diets come from, because sometimes if it's not the sugar, it's the meat, it's the alkaline, the famous alkaline diet, and the patients that swear over those diets that they get better. They don't look about about the other things that are going around. They think that just the diet. But in the reality, I think that with moderation, exercising with moderation, eating with moderation, obviously gaining weight is not in your own benefit. So I think that nutritionist is very important part of the equation, but they need to eat. If you really, plus the torture of not eating absolutely nothing, no sugar, I think that is almost criminal.
Especially foods that you enjoy.
Yeah.
I mean,
Yeah.
Well,
No, we want you to
every
be-
time I eat a piece of chocolate, I say to
Yes,
my
go with for a piece of chocolate.
We want you to be in good spirits so we can fight this. And but something that Dr. Botero just reminded me is obesity is linked to cancer for sure. And among survivors, same thing. Your chances of cancer recurrence or survival are worse when you are obese. So that's why that part, if you are obese or whatever, overweight, yeah, you can do a diet, but you have to consider, especially in lung cancer, patients lose a lot of weight. That's why we rather have you in a good weight than losing weight. That's why diet is very hard in our patients.
So let me just add to that kind of a surgical perspective. People often want to know, what do I need to do to prepare for surgery? And I tell them the most important thing is maintain good nutrition. We want people to be stable or even gaining weight going into surgery, because surgery is a very traumatic event, and your body requires all of its energy stores to heal from surgery. And one of the really interesting bits of data that's come out in the last few years is that people who are actually overweight, that scale from the government about normal weight, overweight, obese, 1, 2, 3, people who are actually overweight have the lowest mortality rate with surgery. They actually do the best with surgery than people who have normal weight.
that piece of chocolate cake.
So maintaining your nutrition.
Name on it.
You're maintaining
there is
your
plenty
nutrition
of
is
cookies
important.
in the back. So there are plenty of cookies there. So.
I just want to say something. I remember 13 years ago when David was diagnosed with cancer. They only gave him days to live by that time. And I remember the first doctor just told us he has days to live, there's nothing to do with him. But someone else told me, get a second opinion. And that's the way I found Dr. Raez. But I remember that when you get cancer, everybody has the solution. Everybody tells you what to eat and not to eat. But Dr. Raez, I guess in a way, he always gave us hope, and that's what we love Dr. Raez. Because he always gave us hope. But I remember they telling us that not to eat sugar and not to eat red meat. And Dr. Raez told David, you eat everything that you want to eat, everything. And David did. And we didn't think that it was because David was going to die, so it doesn't matter. Eat whatever you're going to eat because you're going to die anyway, right? So he ate everything. And look, he's still here. So, and another thing that we learned, like Dr. Botero was saying about Dr. Google, that's something that we are also learned. We don't look at Google for nothing. First, God. Second, you need to trust your doctor. You need to be buddy-buddy with your doctor. And then you don't go to Google, because when you look at Google, everything is bad. You're going to die tomorrow. There's 99% of the people dying. So why to look at that? What you need at that time is hope, positive. So that's what we had learned during these 13 years, and it has been working.
And I think we've talked a little bit about a lot of things today. And each one of these disciplines, plus the ones that Dr. Raez talked about that aren't even represented at this table right now, we could have multiple separate meetings talking, through each different piece and each piece and each role that these amazing people play. But I think for me, what I hope you guys take home is how important it is that you do have multidisciplinary teams looking at your cancer, no one lung cancer is the same, right? Everybody's cancer is different. Everybody, reacts to their treatments different. And so having all of these eyes on your specific cancer is so incredibly important. And I think they would argue and agree, not argue, they would agree that they learn from one another too, right? They all specialize in their own place. And so really kind of having those conversations about any one patient, I think, is incredibly important. I want to say a huge thank you to this panel for coming and talking to us today. An even bigger thank you to all of you who showed up here today and participated and sat here and listened to everybody talk.
And thanks to you for putting to
together.
all of you to put it together because
I want to thank everybody watching online. I want to thank the Beverly boys in the back there for showing up early and getting all this set up today. The historic Maxwell House, I absolutely love this event place. A huge thank you to them for all the work they did before we even got here. I do need to read off this list to thank our supporters. Without the support of in particular, our industry partners who believe that empowered patients, or that patients deserve empowerment and that empowered patients do better. And you heard all about this today. You guys learned from Ben, you guys learned from one another. And it's important that you read up, not through Google, but through reliable resources like your physicians or organizations like GoTo or other lung organizations out there that have vetted and verified, accurate, up-to-date information is really important. So the supporters are Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati Therapeutics, Novartis, Regeneron, Sanofi, and Takeda. That's a really long list, which I think goes to show that they recognize the importance of this patient education empowerment. So thank you all for joining us here in South Florida. I hope everybody gets home safely, and we'll see you next time.
So I'll be brave if you're brave. I'll be brave, but only if you're